Good morning. I am Shankar Raj, President of New Delhi-based HEAL Foundation. Welcome to the 12th episode of the hour-long series on health issues brought to you by IHL Wellness in association with HEAL. We are live on YouTube. This episode has two sessions. The first is on IVF treatment, challenges, and management, and the second on surgery for breast cancer, types, procedures, and recovery. For the first session, we have with us Dr. Nisha Bhatnagar, Medical Director, Aveya Fertility and IVF Center. Welcome, Dr. Nisha.
Good morning, Mr. Shankar. Thank you so much for inviting me for this wonderful session. And thanks to HEAL Foundation for doing such an amazing job.
Our pleasure. It was on July 25, 1978, that the first IVF baby was born in England. That infant, Louis Brown, came into the world surrounded by controversy. It was heralded as the most remarkable medical breakthroughs of the 20th century. There were debates about the ethics of making test tube babies, even the
HEAL Foundation,
and worries that the child or the mother would suffer some kind of lasting health effects. But since then, the world has moved on. In decades since, in vitro fertilization has shifted from front page news to a standard choice available for couples struggling with infertility. IVF, the most commonly performed assisted reproductive technology or ART, is used worldwide by patients and couples trying to conceive. The struggle and heartbreak of infertility affects millions of people every year. Of late, this has increased due to lifestyle changes. The cure for infertility is not simple yet. Now, we have with us Dr. Nisha to answer this, and I will start off straight away asking you a basic question. What exactly is IVF, and can you take us through the procedure?
So basically, IVF is a part of assisted reproductive technologies, that is ART. So whenever we are trying to assist the couple in getting pregnant, that comes under the banner of ART. IVF is not the only treatment. Before IVF, there are various steps. Like, for example, there is a simple step called timed intercourse, ovulation induction, IUI, and IVF. I'll walk through one by one. So what is ovulation induction? As you rightly said, Mr. Shankar, that there is a lot of lifestyle disorders now. Females are not as physically active as they were earlier. So these have led to hormonal imbalances. We see a lot of females suffering from polycystic ovaries. And in such cases, the regular ovulation, formation of an egg doesn't happen, which is a natural phenomena. Normally, it happens every month. Cyclical, it is there. But in PCOS, it is not there. So what we give is we give simple medicine for 5 to 10 days, which leads to formation on an egg. We tell the couple to have intercourse at a regular time, at a regular interval, and at particular time, when the egg is about to rupture, at that time, we tell them to have an intercourse. This is a simple process, not very costly. They can do it at privacy of their own home, and it has a success rate of about 5 to 10%. Then the second is IUI. IUI means for patients who have erectile dysfunction, or the couple are not able to have regular intercourse because the husband has some problems or something. In those cases, and now there is new thing. The husband is working in the night, the wife is working in the day, and they are not able to have intercourse at all because of their lifestyle and things. In such cases, we take the semen from the husband, we process it in the lab, and we just put that semen sample inside the female's womb. That is intrauterine insemination. Again, it is a very easy process, not invasive. Just you have to come 2-3 times for a monitoring of egg. And the cost is also very less. It comes within a purview of about 10 to 12,000 only. And the success rate is about 15 to 20%. But the case selection is very important. Now we come to IVF. IVF is in vitro fertilization. It is not an artificial method. We are just trying to do whatever nature is doing inside the female body. We are doing it outside in the test tube. That's why it is called as test tube baby also. So what we do is that you need to remember that this IVF process can be done with one egg also. That is called natural cycle IVF. In that, suppose the tubes are blocked. Okay. Rest everything is fine. The female is young, she's developing an egg, she's ovulating, the semen is good. So what we do in that case is that we just take that one egg out and we fertilize it with the husband's semen and we put it back into the womb of the female. That is in vitro fertilization. Now, because we are dealing with science, sometimes science is not as efficient as nature. Nature is very efficient. So what we do, instead of having one egg, we give the female some medication, either oral tablets or injections, so that instead of one egg, she develops around 8 to 10 eggs in that cycle. Okay. You need to remember that every female has around 5-6 eggs on the second day of the period in both the ovaries. Out of that, only one grows, rest die down. So we are not depleting. We are just trying to collect all of them. We give the medication for around 8 to 10 days. It is as simple as an ultrasound. It's a transvaginal ultrasound, like you go for getting a scan done. It's the same process. Only thing is that with that transvaginal ultrasound, we attach a needle. Like you give blood test for testing, the same way a needle is attached to that probe, and transvaginally we collect those eggs into the test tube, and thereon we process it.
Now, you said about semen. If the semen count is low, what exactly? Of course, collecting the eggs is okay, but what about the semen?
Okay. So again, when we are trying to go with a natural process, WHO around 10 to 12 years back, the normal definition of a normal semen analysis was around 150 to 180 million sperm per ml. Now, because of the changing lifestyle, because of the changing definition, because of the changing, the whole all over world, the count is coming down. So now WHO has defined as around 15 to 16 million per ml as normal sperm count. Okay. But when we are going for a natural process, this 15 to 16 million should be deposited in the female vagina every alternate day during the fertile window for at least 2 to 3 times. Then there is one sperm which is capable of reaching the reaching the tubes and fertilizing the egg. Okay. But when we talk about IVF and ICSI, we don't need 15 to 20 million. The difference is that in natural process, the sperm, there are many sperm and only one reaches the egg. And there are many attached to the wall of the egg and only one is able to fertilize it. So that 15 to 16 million per ml is required. But when we go for IVF and when we go for ICSI, the sperm count as low as 3 to 4 motile sperm per slide, per field, is also capable of giving a live pregnancy. Why? Because for one egg here, we just need one sperm. We can pick that sperm and we can use it for injecting into the egg. Just let me give you an example, Mr. Shankar. Suppose there is a person who's sick, who's in hospital, okay? And the person is with the IV fluid and everything, and the person is sitting. You ask that person to run a marathon. What is the chance of winning that marathon? Absolutely very low, less than 1%. Okay. Now, suppose you give that person an Audi. The person sits in the car and you tell that now you have to run the marathon. Okay. So what are the chances of that person winning the marathon? Almost 100%. Okay. So this is the difference. When we are doing ICSI, we are selecting the best sperm. We are picking that sperm and we are facilitating by putting it inside the egg, facilitating the fertilization. So IVF and ICSI is a very, very effective method of increasing the chances of pregnancy, especially in cases where the count and motility is very, very low.
Now, you said you take multiple eggs out, and then does it lead to multiple pregnancies also because of this?
Okay. So the reason why we take the multiple eggs out, because science is an imprecise branch. Like human reproduction is very imprecise. Always 2 plus 2 is not going to be 4. 2 plus 2 can be 3, 2 plus 2 can be 5. Okay. So when we have multiple eggs, it's like putting, when I have one egg, the whole thing, the result lies on that one egg only. When I have multiple eggs, I can actually select the best ones out of it. This one is good, this one is good, this one is good, this one is bad, this one is bad. So we select the best eggs. Then we take the sperm, we put it inside the egg, and then we observe the development of the embryo. There are basically three ways where we assess the development of the embryo. We see whether it is growing as per the time or not. We see if all the cells are equal or not. And we see if there is fragmentation in the embryos or not. So any embryo which is growing faster or slower will not give you pregnancy. Any embryo, suppose on day 3, I have a 6-cell embryo and I have a 8-cell embryo. But here all 6 cells are equal. But here 4 cells are big, 4 cells are small. This one will not give you pregnancy, only this one will give you pregnancy. Then if there is a fragmentation in the embryo, we don't put that embryo back. So coming back to your question, the aim of taking multiple eggs is not to give multiple pregnancy. We create multiple embryos and then we can freeze those embryos. If the couple desire to have a single pregnancy, we just put one single embryo back into the uterine cavity. Okay. So all over the world where there is good center, all ethics and everything is followed, all principles are followed, we just transfer one single day 5 blastocyst. That results in a single pregnancy because multiple pregnancy is considered as a high risk pregnancy. It is not a standard. But what happens in India is more is considered better. If you get 1 + 1 free, it doesn't matter what is the quality. So people want that, to increase my chances to have, I want to finish this off in one go. You need to understand the trauma, the stress behind it. They have gone for so long without something like, having a baby is a natural thing, as a normal thing. So they want to increase their chances. There are both ways. The patients want to increase their chances and the centers sometimes are not sure about the implantation potential of that embryo. So what they do is that they put more embryos. So if you put more embryos back, then there are chances of multiple pregnancy, not if you put single embryo back.
Now, if a patient comes to you and wants to take IVF, how long does the procedure actually take place? How many months or how many days?
Okay. So it is a cyclical procedure. So at least one cycle is needed to finish one procedure. Okay. But we start at the second day of the period. For 10 to 12 days, the patient takes the medication or injection. After that, we give you one final injection, which is called trigger. That is for the egg maturation. And 36 hours later, we collect the eggs. Now, there are certain norms we need to follow. There are certain rules. For example, if a patient has more than 10 to 12 eggs, it is not safe to transfer in the same cycle. So what we do is we freeze all embryos. But if a patient has 8 to 10 eggs and everything else is good, there is no problem in the uterus lining, it is beautiful triple line endometrium, the embryos are good, we can transfer it back in the same cycle. That, for example, if we are starting on 1st of October, we will start the injections from 1st of October. The patient will take injections for till 10th of October. 12th of October will be the pickup day where we retrieve the egg. Till 17th of October, the embryos will grow into the lab. On 17th of October, we can put it back inside the uterus. And on 30th of October, patient can do the pregnancy test to know whether they are pregnant or not. So this is one complete cycle. The beauty of this is that if I have more embryos, then I can freeze the embryos, and without going for another cycle of stimulation or anything, in the next cycle, patient can get transfer of one of those embryos again. Okay. So why people are, one thing, Mr. Shankar, I want to tell here is that most of the couple who come to us, they ask about the success rate. They want to know that, what is my success rate? So here, one thing I want to tell is that each human being is different. There are like billion of people on earth and there are billion of fingerprints. There are no two people are same. Even for that matter, if a couple with the same egg and the same sperm, they have 4 children, all 4 of them are unique. All 4 of them are different. Their genetics are not identical. There is some changes happening there. So when a couple come to us, when we see a husband and a wife, we are actually seeing them for the first time. Though I have done 10,000 of cycle, there was none as A and B. They are both different. Okay. So when we do one cycle, we actually understand the response of that couple to stimulation. We understand how what is the egg quality, what is the sperm quality, how they together are forming a embryo. If I have more embryos and I transfer one back, even if the cycle results in a negative thing, nothing to worry. Before starting the treatment, I knew nothing about the patient. But after doing one cycle, we have like sort of doing PhD on that couple. We know how their body responds, and we have enough embryos stored. So even if one cycle is negative, we understand, look, what happened wrong here, what was the problem there, what else can be done to increase their chances, and we transfer the next cycle, and the chances of getting pregnant is around 80% in 2 cycles.
Now, there's a question from one of our viewers. She's asking whether IVF is painful and whether there is anybody, what are the potential side effects while undergoing IVF? Some complain of bloating and inconvenience. So, what are the issues?
Yes. So, IVF, as I told you, we try to mimic the natural process. So, the IVF process is not painful at all. It is our desire, our greed to make it, work in one go, to make it successful, to make it, the more the better, the more the merrier. That thought is painful. What happens because of that thought? We try to give too many injections. Sometimes the doses, we believe in minimal stimulation. So the maximum dose we give is 150 international unit. So if we try to, in an order to get more out of the body, we try to give more injections because there is a lot of money attached to it. Patient wants it to be work in one go. They don't understand that human body is different, science is different. They don't understand the limitations of this process. So in an order to make it more, there are more injections. And the process itself is not painful. These medication and these injection and the wanting to get more, so increasing the dose, that is painful. After transfer, we try to sometimes give it more injections to make it work. But we need to understand the injections are not going to work. You have to be patient with the process. If you understand, if a patient comes to me and tells me that, okay, we understand the limitations of the process and we understand the science behind it, we are patient, we are ready to take the time, then we can do minimal stimulation. We give very low dose of medicine and injection, which is not harmful. Now, regarding the pain and the side effects, when a female has, if you see the natural cycle, when a female is going through cyclical hormones, you understand that even with one egg, she has those feelings of, sometimes she's very moody, sometimes very tender, sometimes irritating, because the hormones are playing with her. So the bloating and the sensation and the heaviness, it's because of hormones. Because instead of one, we are trying to make more. We are trying to make 10 to 12 eggs. So that is temporary. It is for a period of 10 to 12 days only. And nowadays, we are modifying it in a way that we don't do HRT cycles. We do the transfer in the natural cycle. So the pain of injections is decreased. The bloating can be decreased, can be controlled, and the transfer, if it is done in natural cycle, even later on, the injections are less. Okay. So in terms of side effects, the long-term side effects like cancer or something are not there. If you go with a limited dose, if you go with the WHO has defined the dose to be 600 IU. Nobody crosses that dose. So that is, and we do like 150, which is like 1/4. So the side effects in long term, the cancer and all are not there, but temporary side effects like bloating and heaviness, that is there for a period of 10 to 12 days only, not more than that.
And we'll just take a short break. We have a small wellness video and then we'll be back. Very short break. Pavitra, can you play the video? What are the major issues that parents and adolescents face during this particular phase of transition for adolescents?
when I was with the Genesis Learning Studios, I was dealing with a lot of adolescents as the ex-director there. The issues that we deal with are more from the perspective, I'll speak from the parents' perspective, more than the adolescents' perspective here. When we are fighting with them, we're all talking about arguments with the children. We don't stand still. We are always dictative because we gauge parenting with experience. That is one issue. That is the key issue between adolescents and the parents that we face. Second, being heard is a major problem from the child's perspective. It is always about being right for the parent because we have the experience. So you must listen to us. So let's revise ourselves as parents. We really need to rethink that every time we hear the child, the child is going to consider our advice even more seriously. But when we don't listen and we always butt in because of experience, that is when the children start taking us casually. And then we blame social media. Of course, social media has more knowledge than the parents, let me tell you. They do. And we all parents have to agree with it. I'm just speaking facts right now. Issue number 3, children are very smart. Adolescents are always going to jump between childhood and adulthood. You give them responsibility, they won't take it because they want everything on the silver spoon. But they're trying to be independent. And then the horns of the parents stand up and they say, oh, I'm the experienced one. I want to take control of you. You know why? Because I've produced you. So, Dr. Shankar, I don't know if I'm able to specify, but the issues rising are very, very crucial. Separating the behavior and the child. How many parents do that? Every time a child misbehaves, we link the personality of the child with the child. Can we just do away with the behavior and just look at the child? Because the behavior is always guided by a need. Suppose if he's shutting the door and if he's sitting in front of his computer screen for long and if he says, I don't want to meet friends, can we just look at the need why he's doing that instead of just judging him that, oh, he's an isolated child? Issue number 5, freedom, control freak. Like Gagandeep ji said, she said that nuclear families, you're producing only one child or maybe 2 children now. पहले ज़माने में 8-8 बच्चे होते थे. Dr. Shankar, सब पल जाते थे. We all are doing very well, right? We were like amongst 2-3 siblings. Now you have one child, you have one focus of attention as a parent. You don't want to lose control. You want your control on the child because you feel, we balance it with ego that we are not super parents. And if we are not able to manage and control the routine of the child, and we will fail as parents somehow. So these are the basic 5 issues that I look at, Dr. Shankar, which are very, very crucial in balancing the issues of adolescence.
Welcome back. We are live on YouTube. Dr. Nisha Bhatnagar, I'll just take you recently on Friday, that is last Friday, giving hope to a couple, wife was 39 and husband 61. The Kerala High Court has, by an interim order, allowed to extract and cryopreserve husband's semen considering his deteriorating medical condition. This gives hopes to several couples who can't avail the benefits of IVF treatment once they cross the age of 50, as the Assisted Reproductive Technology or ART Act that came into force in 2021 bars hospitals from providing services to women at the age of 50 and men above 55. How do you view this particular judgment?
Okay, see, the thing is that we have to see this from 2 aspects. One is the aspect of the society and one is the aspect of the individual. So if I see from the aspect of society, it is very right that there has to be an age limit. There are couples coming to us these couples specifically who are 60 years old and female is 55-year-old. So what happens is some of them lose their child because of some accident or something. And in India, most of them are coming for the want of having a male baby. Okay, they say that at that point of time, no treatment options were available, and now we want to go for treatment. So if we see from the society aspect that this is right, a couple where the wife is more than 50 years of old and husband is more than 55-year-old, they should not be allowed to bear children, because the female suffers through a lot. There is an age, nature has made an age. Suppose they bear the child at the age of 50. Now, when the child is an adolescent, 60, when the child is 16 or 17-year-old, when the child needs the parents most, the parents would be like 67, 68 years old. How would they be able to cater to the needs of the child? Okay. Now, second thing is that because of these treatment options available, I have seen cases in my own personal practice where the female, though she's not healthy, though she's suffering from fibroids, though she's suffering from problems with the heart, she's forced to carry the child because they had a son who was 20-year-old and he was killed in an accident or something. So they want the mother to go through it, and that is not fair to the lady. Just because from the individual aspect, if a couple is like, now I am 50 and God forbid if something happens or something, I would want to have a child of my own. So to me, I am looking healthy, I am fine, I want to have one more baby. These facilities were not available earlier when I was like 20-year-old or 30-year-old. So I should have the right to go for a treatment option now. I suggest that the court was absolutely right. These cases need to be not generalized, to be individualized. We need to see how that couple is doing. We need to assess that what is their health status, why they are going for this treatment option, whether they can go for this treatment option or not. So till the time we reach a mutual decision about this, it is absolutely right to freeze his sample so that at least the age of the sample stays at 61. It doesn't deteriorate as with the couple.
I think in this case, the Kerala High Court took a very lenient view because
Yes.
of the deteriorating health condition of the husband.
They did the right thing. The right thing.
Now, I just come to another issue is some studies have shown that approximately 1.8% of the children in the fertile group were born with birth defects compared to 2.4% in the IVF group. Is this correct?
So you need to understand the statistics. It's not the procedure. It's not the IVF which is causing this. Okay. This is more detection. Okay. When we see naturally pregnancy happening, so many, I will tell you that around 10 to 15% of the female don't even know that they were pregnant and they had a miscarriage. The bleeding happens because nature has a process of identifying the abnormal babies or something, and the female results ends up in an abortion. They don't even realize it sometimes. However, in IVF cycle, they are closely monitored from the time of putting an embryo back to the time of beta HCG, doubling, frequent scans. The identification and detection of these problems is more. And also you need to understand that we are dealing with an infertile group. We can't compare apple with oranges. We are comparing fertile group with an infertile group. There was some problem to begin with. That's why they were infertile. Maybe some problem in the genes, maybe some problem in the issue. That's why they were not conceiving naturally. So you cannot compare a fertile group with an infertile group. So I would suggest that it is usually more detection, number one. Number two, we were originally dealing with some problem to begin with. So obviously there will be more chances in having a problem in the outcome as well.
One small area of concern is the possible link between fertility treatment and future risk of cardiovascular diseases. Is this right?
So this is sometimes seen more with a frozen embryo transfer cycle, where we freeze the embryos and we transfer. And I again say that it is because of the lifestyle changes. Day by day we are seeing. So it is something in the genes. We are following an unhealthy lifestyle. So if we improve that, I don't think it has anything to do with the procedure itself. I have done multiple cases and I have not seen that there is an increase in the incidence of problems in these babies. I have seen these babies very healthy, happy, as normal as another set of children.
Yeah, the issue is higher levels of estrogen used to induce ovulation.
That is HRT. That
Yeah.
is HRT.
Yeah, that's
So if we don't, now I told you earlier that we are not going with HRT cycles now. We are going with the natural cycles now. So we do create embryos, we freeze them, but instead of doing transfer in the HRT cycle, we do a natural cycle transfer where one egg is producing, the corpus luteum is there, and this one egg is secreting the hormone, and we doing a natural cycle transfer.
You have such vast experience in this field. Now, looking ahead, what do you think is the most exciting thing that is going to happen in IVF?
So there are two things. One thing is there's artificial intelligence is playing a major role here for selecting the good embryos and for selecting the best sperm, increasing the chances of implantation. The second thing which I personally like is that there is a non-invasive genetic testing coming now. Till now, the couple who have any genetic problems, we used to take a biopsy from the embryo and then we used to send it for genetic testing to find out if this embryo is healthy or not. But now with advancement, when an embryo is growing in the media, there is an interaction of the genome taking place between the media and then. So whatever media is left with, it has some amount of genetic material of the embryo. So now we don't need to take biopsy from the embryo. We are taking just that spent media and we are extracting the genetic material from that media, and then we are culturing it and we are trying to identify that if this embryo particularly has some genetic problem or not. This is a very, very good advancement. We would not need to take the biopsy from the embryo, and we can identify without biopsy that if the embryo has some problem or not.
So if you find that after this particular thing, if you find there is any issue, what do you do?
So usually we discard those embryos. We don't, we counsel the patient. We tell them that this might be possible, and we tell the couple that it is not recommended to transfer that embryo. In infertility, you need to understand basic difference is that it is a desire. Okay. So if a couple say that, okay, fine. For example, if I don't have a good embryo, I can't just discard it. I have to tell honestly the patient that this is the potential of this embryo. What do you want to do with it? Then we counsel the patient. Their wishes are taken into account and we take a mutually agreeable decision. So if the embryo is not good or something, we counsel the patient and the patient says, okay, fine, I don't want to transfer it, but I don't want to discard it. You keep it frozen. I will, maybe in future something comes and we might be able to repair it. We keep the embryo frozen.
Very exciting science. I think to some extent you are also playing God. I think that gives you a bit of
just try to be a human. That's it.
Yeah, no, but you're giving hope to so many couples, and as I said earlier in my talk, that couples wait for that particular heartbeat to make their life different. Thank you very much, Dr. Nisha. Thank you. It was always a pleasure to have you with us. Thank you very much.
Thank you, Wellness Matters and Heal India Foundation for giving me this opportunity. Thank you.
The next session will be on surgery for breast cancers, types, procedures, and recovery. Substantial support for breast cancer awareness and research funding has helped create advances in diagnosis and treatment of breast cancer. Breast cancer survival rates has increased, and the number of deaths associated with disease is steadily declining, largely due to factors such as early detection, a personalized approach to treatment, and better understanding of the disease. To speak more on this, we have with us Dr. Shubham Garg, Senior Consultant Oncology, Fortis Hospital, Noida. Welcome, Dr. Garg.
Hi, good morning. Good morning. How are you doing?
Fine. We are all fine. Pleasure having you on the Sunday on an important topic.
Thank you. Thank you for having me. Thank you so much.
So my first question, before we go on to the main topic, what causes breast cancer, and are some women more susceptible to breast cancer?
Right. So I was actually hearing a part of the first topic, the one on in vitro fertilization, and these two things are very closely linked. So first, it's very common for a layman to ask what are the causes of breast cancer, but unfortunately, till now, we have not been able to pinpoint a cause of breast cancer. So like we can say that tobacco causes head and neck cancer, but there is no one single factor which can lead to breast cancer. Having said that, we have a set of conditions which can increase the risk of having breast cancer, but we don't cause them. We don't call them the cause of breast cancer, but we call them risk factors of having breast cancer. So I will just rephrase that question into, not just causes, but what are the risk factors of having breast cancer? What things increase the risk of having breast cancer? And one of which is nulliparity. So nulliparity is not having an issue or not having a baby. So that is the foremost reason. Second, having an issue after the age of 30 years. With our working lifestyle, we are getting more and more late parenting, which is also leading to more and more people choosing to go for in vitro fertilization. So all these things increase the risk of breast cancer. This does not mean that everybody who has a kid after the age of 30 will definitely have breast cancer, but those who have their first kid after the age of 30 would be at a greater risk of having breast cancer. Similarly, hormonal manipulation, too much ovarian stimulation, too much use of hormonal pills can again lead to a risk of breast cancer. Very early starting of your periods or very late finishing of your periods, that is early menarche or a late menopause, are again said to be risk factors for breast cancer. Genetics are playing huge roles, and patients whose mothers or mother's side or female relatives on the father's side have had breast cancer would be at a greater risk of having breast cancer. So these would be the factors that I would put attributable to higher risk of breast cancer.
Now, speaking on this particular subject, some lifestyle changes like smoking, consumption of alcohol, lack of exercise, diabetes, do all these also a contributory factor to that probably will increase the risk factor?
Right. So there has been a correlation between obesity and breast cancer, as well as smoking and breast cancer, but there has not been any correlation between alcohol and breast cancer. But we see all these as our lifestyle modifications. So people getting married late, having late kids, not having kids, a more hectic work style leading you to lesser time to exercise, greater sedentary lifestyle, inability to maintain weight, not an active lifestyle, all these things will increase the risk of having breast cancer.
What are the different types of breast surgeries that are now currently available?
Right. So surgery forms the cornerstone for breast cancer treatment. Whenever a patient comes to us, they ask us different options which are possible, and surgery is the foremost and the best option available. There are two basic surgeries that we can offer. One is what is known as a mastectomy. Mastectomy means complete removal of the breast. You remove the breast along with the nipple, along with the lymph nodes, and that is known as a mastectomy. People might have heard the short form as modified radical mastectomy or a MRM. The other surgery that is possible now is a breast conservative surgery, where we try to maintain the shape or the mound of the breast with or without the nipple areola complex, and we remove the lump along with a wide margin. So a wide margins for an oncologist comprises at least 0.5 to 1 centimeter. 1 centimeter is desirable, 0.5 is the minimum that we want. That would compromise of a breast conservative surgery, where we will be able to give you a cosmetic shape of a breast. These are the two major kinds.
Now, how and when do you choose between breast conserving surgery and mastectomy?
Right. So one of the major deciding factors is actually the patient and not the surgeon. But obviously, we have the last say in terms of whether the patient is fit enough to be offered a breast conserving surgery. So come what surgery it may be, the first goal is that it has to be oncologically safe. Oncology safe means that we are not going to leave any disease behind if I'm offering you a breast conservative surgery. So we have a healthy discussion with the patient in which we ask for the goals that the patient seeks to achieve after having a breast surgery. What our basic requirement for offering breast conservative surgery is that your breast size should be big enough to allow removal of some piece of the breast without compromising on too much on the size of the breast. That is one. Second, you should be able to receive radiation after this. Why I say so? Because just a breast conserving surgery is not equivalent to modified radical mastectomy. If you add radiation to breast conservation surgery, only then are the chances of the disease coming back similar to MRM. So the first criteria should be that the patient is willing to take radiation after breast conserving surgery, or they come from an area within the country where radiation is available. If they tell me that they are not able to take radiation because of either logistic reasons, or they don't understand radiation, or third, they cannot afford radiation, I should not be offering them breast conservative surgery, because then I will be doing a lesser of a procedure and not being oncologically safe. So the first thing should be that you have to be oncologically safe. You should be able to get a good margin around the disease. Second, radiation facility should be available. And the third, the patient is desirous of having a breast conserving surgery. These are the three cornerstones for making a decision.
When you do MRM, do you need to give radiation on a?
So yes. So it is not that if you do MRM, you will never require to give radiation. But if you do MRM, one of the indications of giving radiation is that the tumor size has to be more than 5 centimeters. So if the tumor is more than 5 centimeters, so anyways you are going to require radiation, whether it is breast conserving surgery or MRM. Second is, if your lymph nodes in the axilla come positive, you will be requiring radiation. So if your stage is high enough where the tumor size is either more than 5 centimeters or the lymph nodes are positive, you will anyways going to require radiation.
Now, we have a question from one of our viewers. It says that quite often the doctors say that I have developed lymph nodes sometimes. And what exactly are these lymph nodes and nodes, and how are the surgeries done to remove it, and are they always dangerous?
So lymph nodes, if you can take it as it's a filtering station. It's a filtering station from all the fluid that goes out of our breast or any tissue in the body before it reaches the blood vessels. So all that blood which comes out of the breast goes through the axillary lymph nodes which are in your armpit and then reaches the blood vessels. So many times it happens that the cancer cells might traverse through your blood vessel and reach up to the lymph nodes or the lymphatics, and hence it is imperative that we examine the lymph nodes before committing to a surgery and decide the management. Lymph nodes also decide what is going to be our stage. It is not just the size of the disease, but also the positivity of the lymph nodes which decide what is the stage of the disease. That is why addressing the lymph nodes is very, very important for not just breast surgery, but any cancer surgery. This is what differentiates it from a general surgery and a cancer surgery, that we always address the lymph nodes. Having said that, when we choose the type of surgery that is done, in case of modified radical mastectomy, through the same incision, we always extend the incision up to the armpit and take out the lymph nodes which are there inside the armpit. Now, they are always in relation to the blood vessels. So the main blood vessels which supplies your blood to the arm, we remove all the tissue, all the fat around that area, which comprises the lymph nodes also. In case of breast conserving surgery, we sometimes need to give a separate incision on the axilla to remove all those fat and the lymph nodes.
Now, what are the risks or complications of breast cancer surgery? Can it cause blood clots, nerve damage, hematoma, etc.?
So, breast as such is a skin appendage. You have to understand that the breast is hanging outside of our body. So we are basically doing a surgery for thing which is outside the body, and we do not enter any body cavity. So breast surgery as such is said to be risk-free. But when we deal with the lymph nodes, it is at this point in time that we are either close to the blood vessel or the nerves. And it is at this point that we come across the complications that you just mentioned. So the common complications that we come across after breast surgery is one, lymphedema, or which is also, you might have seen some patients having a very swollen hand after breast cancer surgery. And that is because when you remove the lymph nodes, all the blood that returns through the hand to your heart is not able to reach all that area. And that is why there might be some thickening of that arm. Secondly, also because you disturb that area, the nerves which are traversing that area, you might have loss of some sensations or altered sensation in the back of your arm or around this area. Vascular injury, if I may add, is very rare and usually not seen in cases of breast cancer surgery. But yes, it's a theoretical possibility, and we always explain our patients about that.
The majority of reconstruction procedures involve breast implants. How safe are they? And do women experience pain as well as decreased range of motion in the shoulder once they go for these implants?
So that is a common misconception that most of our patients would require a breast implant. In fact, breast implants are usually not always recommended after breast cancer surgery because our patients also require some amount of radiation and chemotherapy later on. So if a patient is desirous of having a breast after a mastectomy, what we usually offer is an oncoplastic reconstruction where we take tissue from some part of the body itself. It can be your back, it can be your abdomen, and we try to create that mound. Yes, there are some patients who might not be able, don't have that body mass to give us that fat. But in those cases, what we do is we allow them to complete their treatment in terms of radiation and chemotherapy. And probably after 1 year down the line, we might offer them or they might choose to take a breast implant. These implants are silicone based and usually they are pretty safe and do not cause any impairment of daily bodily activities, which include shoulder movements. In fact, they are found to be very, very satisfying in terms of the patient experiencing a good cosmesis and having a real boost in self-confidence.
How long is the recovery from breast cancer surgery, and can it cause some stiffness or unease?
So, in my clinical practice, I've realized that recovery is all that is there in the mind. I have had patients, who are working females who join work within 7 to 10 days after surgery. And I have had patients who are homebound and they continue to complain even 2 months after surgery that, what have you done? And I'm not able to move my hand. But believe me, you will be up and around and moving around. You will be eating by yourself immediately after breast surgery. Post-op day 1 is when we expect the patients to be sent home. All your sutures are usually removed on day 10 to 14. You can do your normal activities as soon as week 3. And we in fact start our patients on chemotherapy by 21st to 28th day. So imagine if you're fit to take chemotherapy, you're definitely fit to do your normal work.
One problem with breast cancer is that they come late at a very late stage, and the easy method out is to have a mammogram. How accurate would be a mammogram? And this is still a golden standard.
Right. So, see, mammograms will be able to pick up diseases which are as small as 9 mm. 9 mm is less than a centimeter. If I palpate it, I will be able to pick up diseases around 1 to 1.5 centimeter. If a patient does it by herself, she will be able to pick up diseases as small as probably 2 centimeters. So mammograms are good investigations, but they are suitable only for patients who are self-aware. If you are self-aware, you might as well examine yourself and come out with disease which is almost 2 centimeter. If you're able to pick up disease which is 2 centimeter, you will still fall in stage 1 of cancer. So mammograms are advised. We tell our patients to do mammogram, but I think the first message is that we should make them aware about this disease and tell them about self-breast examination so that they can do it. Mammograms should be done after the age of 45 every year, and they have been found to reduce the risk of death by breast cancer by as many as 20%.
Now, in one of our shows earlier, in this IHL Wellness show itself, we had a startup from Bengaluru where a doctor had come up with artificial intelligence for detecting breast cancer. And she says that after all, mammogram is a reading, and once you have an algorithm, it's easier for you to detect any lump or any issue with the breast quite early enough. So do you see a role of AI in breast cancer detection?
So like it was being spoken in the last topic, AI is something that we doctors look forward to contributing more and more to the medical science. But I would put it this way that AI should not be over. We should not have much expectations of AI when you are not using the resources that are easily available. I would want an AI to take a decision for me when my radiologist says that he has 200 mammograms waiting to be reported. If he has only 5 mammograms in a day to be done, he's very well able to do all those reporting. So why would I risk my thing on an AI when I have a human resource? So my thing is that AI would help us definitely in a scenario where every person gets a mammogram done, because at that time it will be a diagnostic nightmare for me to look at all those mammograms. So AI would help us at that point in time, but right now we are not at a stage where we can use AI because we are not using the resources which are adequately available.
We'll take a short break and then we'll come back. Just a small wellness video which we will play in between. Over to you, Pavitra, for the video. You suddenly become body conscious when you're a teen and you have a lot of developments which you are not, of course, ready for or you didn't expect. Now, adolescents also have a problem of, being obese or being extra thin. And there's a lot of body shaming also happening across. So how do you deal with such? How can adolescents deal with such a situation?
I think one of the things is that, when the body... when you reach your adolescence and hitting puberty, the body changes are very drastic. Before you know it, it's done. It's not a very gradual thing. And accepting those changes sometimes can be very, very painful, especially if they are related to, in terms of weight, if they are related to appearances, change of appearances. And it does take them some time to actually get used to the new way they look, I think preparing these adolescents is very important. This will happen. You would put on a little weight, you will have a little weight on your breast now, or you will feel a little, you will get taller, or you will not get taller, or you will, have these spurts of growth at this point in time. And, or you might have acne, which is very normal and it can be treated. There's no problem. But as even families I've seen, I don't know what he does. I've told him not to have spicy food, this food, that food, but yet he does it and he has acne or she has acne on her face right now. So we are not talking anything about body positive, but we are talking in a way which is making them even more and more conscious about their appearances. One, that they are conscious about their appearance, but the conversation at home, school, peers is all about what has changed in your appearance. And I think that is a big, big burden. And if we are prepared as a family, prepared as a class, it's much easier for everyone. But I think that preparation doesn't happen. I don't even think that many schools have, sexuality education in their curriculums, but boys are put separately, girls are put separately, and they are told not to have sex. That's like the aim. But nobody is addressing, unless they are coming to sessions to a psychologist one-on-one. Some parents are very, very, open about, they read, they explore, but a lot of young adults do not know what's coming up next for them, how to deal with it, what is the change. And if we have those prep stages very well, I don't think they will be feeling so much of it as they feel it right now. I've also seen a lot of young adults who have gone, searching on the internet. And once they see that, there are other people like me who don't know too much about their orientation, or they don't know what is going on with their body, they feel very, very supported at that time. So, there are some young adults who will go back and, search the internet of what problems they feel and resonate with something. But that can misfire as well. So if we have a, reliable source that gives them that support, or a support system through this, that's way, way more better.
Welcome back, Dr. Garg. In August this year, the US Food and Drug Administration approved Enhertu, an IV infusion for treatment of patients with HER2 low breast cancer. Now, this is the first approved therapy targeted to patients with HER2 low breast cancer subtype. Now, is this drug available in India? And before answering this, please explain what exactly is HER2 low breast cancer.
So, what has happened is that we have moved from now just offering treatment to breast cancer, but to subcategories of breast cancer. So HER2 is one of those targeted therapies that we want to aim at. HER2 basically refers to receptors which are present on the nucleus of the breast cancer cells, and not all patients have HER2 positivity. Once we do a biopsy or once we do a surgery, we send that specimen to be tested, not just for the what is the type of the disease, what is the size of the disease, but what is also what we know as the molecular subtyping. So now what we're trying to work it as at a molecular level. We are not just removing the disease and treating it. We are just trying to look at what was the target that we can achieve. And then if we could give a targeted therapy, we would have lesser of the side effects and more of the effectivity. So HER2 is one of those targets that we want to look in a breast cancer. And if it is positive, it is a good thing for us. Then we have one more medicine, which is the Enhertu, which can use to be targeted. So now there is some lack of knowledge here when I say that HER2 is not something new. HER2 has been there since 2010. And the first drug which was there to target HER2 is now actually been available since 2012 by the name of trastuzumab. And initially, it was a patented molecule, but now for the past 3-4 years, the patent has expired. It is now very easily available in the Indian market. What Enhertu is that we are talking about is actually a newer molecule which helps us tackle the patients who have received trastuzumab and now again have a relapse. So because they have a relapse, we cannot offer them trastuzumab because these cancers are resistant to trastuzumab. So they give us another option of targeting these cells through this new drug that we are talking about. So what we are trying to do is breast cancer patients have a long journey. They receive first line, second line, third line. This is one of those new armaments that we have in the fight of breast cancer, where we tackle relapsed breast cancer or resistant breast cancers to the first line of therapy. So Enhertu is actually a second generation of drugs targeting HER2, which have already taken the treatment for the first generation, which is trastuzumab that I'm speaking about.
Is Enhertu available in India?
Enhertu is available in India, yes.
So the news is that just FDA approved it recently in August.
So that's what I'm telling you. Gone is the time when the drug was introduced in the US, approved by US FDA, and then it took 8 years to come to India. Now, as soon as they are launched in India, they are easily available here. It is just that when they're initially launched, the price is very expensive and most of our patients cannot afford it. But availability is never a problem. Accessibility is the problem.
Now, coming to a more common question, what are some of the myths regarding breast cancer? Some people say it is associated with bras, it's associated with wire bras. There are a lot of myths regarding. Can you just throw light on that?
So that is a very common misconception that we have, and we have a lot of young patients walking out to our OPDs and telling us that they have some lump in the breast and they feel that it is probably because of the wired bra. So wired bra has never been found to be associated with a higher risk of breast cancer. But yes, wired bra can impinge on your breast tissue, especially if it is an ill-fitting one, because it's a mechanical contraption and you're allowing your body to be entrapped in that. So obviously it can, if it is ill-fitting, it can impinge on the skin and your breast tissue and cause some injury. But again, wired bra has not been related to breast cancer. But a very common misconception that has been brought to our notice and patients come to us is when we tell them that, you should get a biopsy done for this, for your breast lump, and they come up to us saying that, a biopsy will make it actually grow the disease faster and the disease will spread. So it is very difficult for an oncologist, be of it any caliber, to put his hand and say that this is breast cancer. Even if I say breast cancer, I cannot start you treatment till I know what type of breast cancer it is, whether it is breast cancer or not. And now, like we are talking about HER2, what molecular grading of breast cancer is. And that is why we need the biopsy. Biopsy is a very safe procedure in case of breast cancer. It's a OPD procedure. You don't even need admission for it. And it definitely does not cause breast cancer to spread. I think that is one of the most common myths that we come across, actually.
Now, one last question is, what is the most exciting thing happening in breast cancer treatment?
Right. So the most exciting thing which has happened very recently is a new Tata Memorial study, which has brought to light that, giving a very low-cost injection around the breast lump can reduce the chances of the breast cancer spreading. And why it is exciting is that, one, it's an Indian trial. It's a very reliable trial. I have been at Tata Memorial, and for a very, very short time, I was a part of that trial. So it is a very well done trial done by Indian people. A good number of patients have been involved in it. And the impact it can have is that by just spending 120 rupees during surgery, you can reduce the chances of the disease coming back by as many as 20%, which is actually unheard of. See, whatever new things which are happening have been happening in the field of medical oncology, where we see new and new drugs coming, like we spoke about Enhertu. But these are very expensive and probably not available. Most of the people cannot afford it. But an intervention like what Tata Memorial has come out with is actually groundbreaking and will have impact at the grassroots level. We are yet to receive the final publication for it. It will still be debated a lot in the world media, and only once it is approved and standardized will we be able to use it as a standard procedure. But it is a very good beginning for us.
And this I understood is very cheap as rupees 30, because it's a local anesthesia that's given.
Yes, it's a local anesthesia, and it has to be given around the breast tissue, around the cancer tissue, and it reduces the chances of breast cancer spreading during surgery and after surgery. So that is why it's an intervention which can be done by you don't need to be in a very 5-star hospital to offer this to your patients. Anybody can do it, any place they can do it. It is just that we need to we need not to be again overexcited by the results. We need to have a unbiased opinion. Just because it's an Indian study, I will not say that it's a very good. We have to see the whole paper. It is just an abstract which has been published, but I am sure that it will create a lot of impact for us surgeons for treating cancer.
I think now Tata Memorial has taken it to all their hospitals for and what, as you rightly said, is multi-centric study, and see how effective it is. Thank you very much, Dr. Chamatkar. I think it was wonderful having with you on this particularly important topic that affects a lot of young people also. Thank you very much. And on behalf of HEAL and also IHL, we thank you profusely.
Thank you so much. Thank you so much.
Namaskar.